Thank you for joining us at the CTSNet Roundtable, where we will be discussing lung cancer surgery in the era of immunotherapy. My name is Mara Antonoff, and I'm a thoracic surgeon at MD Anderson Cancer Center in Houston. And I'm joined today by several thoracic surgeons who are well-known experts on this topic. We'll start by getting to know our panel. Can you all please introduce yourselves?
My name is Boris Sepeshian, and I'm a thoracic surgeon at MD Anderson Cancer Center. I'm also an assistant professor, and I participate in clinical trials with immunotherapy.
I'm Linda Martin. I'm a thoracic surgeon at the University of Virginia, where I serve as an associate professor. I also have quite a bit of activity with the Alliance for Clinical Trials, and I'll be starting a clinical trial in stage 3 lung cancer using immunotherapy.
My name is Stephen Broderick. I'm a thoracic surgeon at Johns Hopkins in Baltimore. I'm an assistant professor of surgery with an interest in clinical outcomes and thoracic oncology.
Terrific. In recent years, developments in immunotherapy have brought about enormous changes in the ways that we think about treating patients with a variety of malignancies. Today, we're going to discuss how immunotherapy has changed the landscape of surgery for lung cancer. Dr. Martin, let's start with you. Can you share with the audience a brief overview of the situations in which immunotherapy is currently being used for lung cancer patients as standard of care?
So there's been quite a few major developments just in the last year or two, but they've all made it into practice and they're in our NCCN guidelines. So presently, for stage 4 lung cancer, it's the first line of therapy either alone or in combination with platinum doublet therapy for both squamous and non-squamous malignancies. And in stage 3 disease, the current standard of care is for inoperable stage 3, for example, bulky N2 disease, that patients would receive chemoradiation followed by 1 year of durvalumab therapy, which is a PD-L1 inhibitor. And also, if you look at the superior sulcus algorithm for patients who are not considered surgical candidates, that is the same regimen that's used in that population as well. Beyond that, so any operable disease, it would only be in the context of a clinical trial.
Terrific, that's very helpful. So Dr. Sepeshi, what kind of results have we seen from the use of immunotherapy, and do all patients respond well, or is there variability in how we might determine which patients are more likely to respond to immunotherapy?
So once again, if we divide the lung cancer into metastatic and non-metastatic setting or surgical resectable setting, we have the majority of the data from metastatic setting, and that response rate appears to be quite excellent in about 20% of patients. So not all patients respond to immunotherapy. Immunotherapy in metastatic setting does seem to be better than chemotherapy, and that's why it has been approved as a first-line therapy depending on some of the biomarkers. One of them is PD-L1. Durability of responses are longer. In surgical lung cancer, again, it was mentioned that immunotherapy is only tried right now as part of clinical trials, and those objective response rates defined as major pathologic response. So when the pathologist looks at the response rate, they have ranged between approximately 22 to about 43 to 45% in one of the first phase 1 trials. Objective radiographic responses, they have been approximately 30% in our NeoSTAR trial, but objective responses radiographically have not really been observed in that small phase 1 trial that was previously published. So we are eagerly awaiting outcomes of some of these trials that are ongoing, especially in a surgical setting.
May I ask Boris a question? I'm wondering what your experience has been with the phenomenon of pseudoprogression. And I mention that because the radiographic response may not be apparent because there's actually tumor lymphocytes surrounding the tumor that radiographically look like tumor, but in fact, it's actually your own host response to the tumor.
Correct. So in fact, we are preparing a short case report as a manuscript on this from our NeoSTAR trial, because pseudoprogression has again been described in a metastatic setting, and it wasn't described in the first phase 1 trial. That trial used only 2 doses of immunotherapy. Our trial uses actually 3 doses of immunotherapy, and we have seen pseudoprogression more in mediastinal lymph nodes. Where following immunotherapy, either sarcoidosis or some granulomatous disease within the mediastinal lymph nodes have been reactivated, and that really makes it important for the surgeons and all the clinicians treating patients with immunotherapy to properly restage patients so they don't just make decisions based on imaging such as PET-CT scan. So it is a phenomenon. It may be occurring, in fact, in up to 15% of patients, and it's a new thing that hopefully we'll report soon.
Yeah, it seems like a lot of areas that we're going to be relearning about.
Correct.
Absolutely. Another area of interest to us, particularly as surgeons, is how these types of therapies can affect our surgical procedure. And so I wanted to ask you, Dr. Broderick, there have been a couple of key studies that looked at immunotherapy in the neoadjuvant setting. Can you tell us about your experience or that of others with regard to operating in these circumstances? And are these operations technically any more challenging or different than a different procedure where immunotherapy hasn't been used?
Sure. So we were fortunate to participate in an early phase 1 study in which patients received 2 doses of neoadjuvant nivolumab for stage 1B to 3A. The majority of patients later stage 2B and 3A patients. Importantly, while we learned a lot pathologically in terms of response rates, that trial was designed as a safety and feasibility trial, and we found that there were no delays to surgery, so no patient was delayed from their planned operation, and there was no increase or untoward findings at the time of surgery. So there were no operative mortalities, and there was no increase or adverse safety signal in terms of operative or post-operative complications. In terms of assessing the technical difficulty of the operation, we don't have an objective measure for that. As I mentioned, 2/3 of the patients were 2B and 3A, so we're talking about patients with bulky tumors, central tumors,
That would be technically challenging.
challenging anyway. They all had hilar and mediastinal nodes. Subjectively, I don't think the operations are any more challenging than similar patients who received neoadjuvant chemoradiation. The nodes are a bit larger, they're inflamed, there is the question of pseudoprogression. The first case I did, I was sending frozen sections on lymph nodes for 30 or 40 minutes, thinking that the patient had progressed. They were all benign, but I think that as long as we're aware of that going into surgery, they're not technically any different than other 3A patients who receive neoadjuvant treatment.
I think we all have anecdotal experience. For me, I did one case where it was particularly challenging in terms of the amount of adhesiolysis that was necessary. That seemed to be quite extensive compared to similar cases where patients hadn't received the type of immunotherapy first, but it's been variable experience among our cases, and I know that Dr. Sepeshi has had other operations that wasn't the case at all, and so it's very difficult for us at this stage of the game to really make assessments, and as you mentioned, without real objective ways to measure extent of adhesions or potentially time spent doing adhesiolysis or estimated blood loss, or can be surrogates, but it's a challenging thing to describe, especially in a patient population, as you said, that may be technically difficult anyway due to the fact that they may have hilar and mediastinal lymph nodes involved.
Have there been any safety signals on the NeoSTAR trial in terms of length of hospital stay or post-operative complications?
Yeah, again, I would like to speak maybe only about some of the preliminary data that we have put together that we presented at ESMO, because we are planning to publish this trial soon as a completed trial. But to answer that question, no. Even in our preliminary data, the length of stay is about the same as what it's for our usual population, about 4 days. I agree with Mara that we do have anecdotal cases of patients who have never been operated on or their chest was not instrumented. So you would have assumed that the operation would be actually pretty smooth, and there was some level of inflammation. And I have been thinking about some subjective way, at least some sort of a surgeon's subjective way of classifying, is this dissection kind of standard? Is it easier or is it harder than what it would be? And I think that we are going to look into this, as well as we're going to look into whether the level of complexity of the operation in terms of inflammation is associated with the response rate. And then there have been some suggestions of potentially doing some translational studies with actually pleural biopsy and involving pathologists and trying to more objectively then identify the level of pleural inflammation and then again correlated with response rates. But that's all part of the future.
I have a question for both of you. Because pneumonitis is such a frequent complication of immune checkpoint inhibitors, I know we all tend to get pulmonary function tests when we first meet the patients. I'm curious if you checked pulmonary function tests after the immune checkpoint inhibitor was given before operating, and if there's a difference.
Yes, so actually we did, and I'm going to be giving out all the data over here. So there was stay tuned for that. Actually, pulmonary function tests are static tests. So we are testing both FEV1 and DLCO, and we did for that specific reason actually check pulmonary function tests before and after. I think in retrospect, I think what would have been important would be to check 6-minute walk test. And I also would like to point out there was a recent publication that was actually in this December JTO journal that demonstrated, in fact, I think 17 or 18% of pulmonary complications with the atezolizumab trial. And that's much higher than what has been reported before, which was about 3 to 5%. And I have to say that as compared to the first phase 1 trial, our NeoStar trial does have some pulmonary toxicities, and we had some patients who fell off the trial and could not undergo resection because of pneumonitis. So immunotherapy is really an excellent advancement in lung cancer, but I think as we're learning more about operating, we also have to be very good about being able to identify side effects and autoimmune toxicities, even as surgeons.
Right. I mean, maybe we need to redefine the interval between therapy and surgery. Maybe it needs to be different than our traditional pathways. It's all areas of exploration.
Correct.
That's right.
Our trial has actually a delay of 21 days that we do operate on patients after 21 days after the last dose of immunotherapy.
I think we're seeing in the medical oncology literature too an evolution of who are the appropriate patients for checkpoint inhibitors and in which patients they should be avoided, and that will certainly.
And I completely agree with that. As effective as this therapy is, we know that it's effective 20, 30 patients, hence a lot of translational research that we need to do in order to appropriately identify the patients who will benefit the most and that way avoid potential toxicity with other patients.
So a question for you all that probably many of our surgeons in our audience may be wondering about how this is going to affect their clinical practice in terms of the types of patients on whom they'll be operating. And in some settings, we've really seen remarkable responses to immunotherapy such that patients who were previously deemed unresectable may now actually be candidates for local therapy. I'm wondering if you guys could please speak on the ways in which immunotherapy may be changing the types of patients on whom we'll be operating. Are we going to be operating on more stage 4 patients with local attempts to cure what was previously metastatic disease? What do you foresee as the future?
I think that may go two ways, and maybe both ways simultaneously. I agree. You may find us operating on more advanced stage patients, patients multi-station N2 who traditionally may go for definitive chemoradiation may become operative candidates. But also, you need to be careful about doing this, but if you abstract the specific data from 3B to 3A, for patients who are borderline operative candidates physiologically with 3A disease, they now no longer necessarily need to go to surgery. They can have chemoradiation followed by durvalumab with durable responses. So I think we may change who we select to operate on in 3A, but also operate on more patients with more advanced disease.
Sure.
I differ in that opinion a little bit. So the Pacific trial has been really revolutionary, as we have discussed, and really established durvalumab in the adjuvant setting. However, the trial at this point has reported 2 years overall survival rates. Oncologically, we have always judged survival rate at 5 years. So we still need to wait for a longer follow-up. One thing that I couldn't find in the trial, which demonstrated two very important things, which was decrease in number of metastases and decrease in number of brain metastases. But we really don't know what the local regional disease control was in those patients who were on the trial. They were deemed surgically unresectable, but that could be for various reasons. Was it physiologically? Was it because they had multi-station N2 disease, etc.? So I think it will be very important to sort out which of those patients actually could be treated with lobectomy, let's say, and complete mediastinal lymph node dissection. And one last comment that I'd like to make is the NADIM trial, which is a phase 2 trial from Spain that is treating patients with 3A surgically resectable disease, has demonstrated unprecedented complete pathological response rate in 60% plus additional 20% of major pathologic response. Now we're talking 80% of patients responding to combination of chemoimmunotherapy. So I do think that we will be converting some patients who were previously unresectable or had large extent of the disease, and we will probably be operating for some local regional disease control in well-selected patients. But this is where we need to be careful about very good surgical outcomes, patient selection, good multidisciplinary discussions with our colleagues, etc. So I'm hopeful that that may come in the future.
So I think some other things, I have an anecdotal case that I was really surprised by the outcome and encouraged by the outcome. I had a patient sent to me with a superior sulcus tumor that was over 10 centimeters. They had had non-traditional treatment because they had some intolerance of chemotherapy, so they only got radiation, so very much off the beaten path of what we're used to seeing. And when the patient came to see us, it was clear that there was no way to get this tumor out completely because of its size and invasiveness. And she had a high PD-L1 score, so we gave her 4 cycles of platinum and checkpoint inhibitor. And the tumor decreased in size by half.
Oh.
I operated, and it wasn't an easy operation because it was still a big tumor, but we got R0 resection, and she was YP-T0N0 for something that was incurable. So, again, that's anecdotal. I'm sure that doesn't happen every time, but I think we will see more and more of these cases.
Right. It highlights the fact that we still have a lot more to learn about how this is going to impact our practice. You've mentioned some interesting findings from some trials in which you're involved, and without going into great detail on the trials, I'm wondering if, just for the sake of our viewers, that they can understand what's coming in the pipeline, if you could just highlight the trials in which you're involved and explain what the key question is that you're aiming to answer, if you wouldn't mind sharing with us.
So I think that for the neoadjuvant trials with immunotherapy, I think really the key question is to identify patients and identify the biomarkers or surrogate endpoints for these trials. So then we could much faster advance this to standard of care and run phase 3 trials. And there, in fact, are already phase 3 trials ongoing. One of the major surrogates that we are looking at is the major pathological response. However, that is a surrogate that has been demonstrated to be associated with or correlated with overall survival, but it's not quite yet accepted by the FDA. So majority of these trials still need to have event-free survival or disease-free survival, but many of these early neoadjuvant trials are looking at sort of biomarker safety, major pathologic response as the surrogates of the efficacy of the therapy.
Any specific trials in which you are involved in that you can share with us the main outcomes that are being measured?
Yes. So we have a trial through the Alliance Foundation that is just about to get underway. It's going to be a 55-patient phase 2 non-randomized trial looking at N2 positive patients, so stage 3A and B, because now we have 3A, B, and C, and people are so used to it being A and B.
Sure.
So it's going to be the Bs that are the good Bs. So anyone has proven N2 disease, and again, that nebulous thing of it looks surgically resectable, they will get a platinum doublet with durvalumab, and there's a slight difference in the doublet depending on squamous or non-squamous histology. Restaging studies, as long as there's no progression of disease, they go on to surgery, followed by 54 gray of radiation, and then 1 year of durvalumab therapy. So it's like the Pacific trial, but interposed in the middle is surgery, and the radiation is given afterwards. And I think that's an area we don't yet know is the combination of chemo, radiation, and checkpoint inhibitor together. We don't know what the toxicity is, therefore we did not include that in our trial design, but that's a question to be answered. And in this trial, our endpoint is N2 nodal clearance, which is a surrogate for disease control and survival. We will certainly, as a secondary endpoint, be looking at overall survival, event-free survival, and the more traditional endpoints, but this should give us an early signal to know if this strategy is effective. And we have lots of biological correlates to look at as well. A huge appeal of all of these neoadjuvant trials is to get the little biopsy the traditional way, and then the big biopsy with surgery, and to be able to look at the cells and all of the biological markers that go with that. And that's sort of a holy grail, I think, that we haven't had with stage 4 disease.
I think, as Dr. Spacey mentioned, there are 3 now phase 3 trials that are enrolling. I'm involved in the Checkmate 816 trial, which is neoadjuvant nivolumab versus combination chemo nivolumab. That trial is about halfway accrued with the primary endpoints of event-free survival and pathologic complete response, getting away from that MPR designation. There are also phase 3 trials for atezolizumab and pembrolizumab compared to those agents combined with chemotherapy versus chemo alone, which are also, I believe, powered for survival rather than just MPR.
And those trials are all at least stage 2 and 3, or some are 1B through 3A, right? So a more
Correct.
Heterogeneous population than the trial that I'm running.
Absolutely, that's right. Yeah.
That's a terrific overview of the trials as they exist at this time. So we've talked a little bit about metastatic disease. We've talked about previously unresectable disease that's become resectable, and some of the middle cases of patients with 3A and 3B disease. Let's shift our focus a little bit to early stage disease. And this is maybe a situation where I'm asking you to predict what you think the future might hold. But surgery's long been the standard of care for early stage lung cancer. But as you know, there have been attempts in recent years to introduce other treatments, for example, SBRT. And I'm wondering if you see immunotherapy as another disruptive innovation. And is it possible that immunotherapy could change the role of surgery for early stage disease?
Nobody knows that for sure. I think I have heard of some institutional trials looking at use of SBRT in combination with checkpoint inhibitors. And so again, these are very small studies and we'll only get some preliminary information. Obviously, we would be looking to use that in a non-operative population. Translating that to an operative population is, I suppose, could happen. I know that is threatening and worrisome to some surgeons. I look at it differently. I think of myself as a lung cancer doctor, and I'd like to have a handle on all the different technology that's out there. And if it means I'm going to operate, that's great. But we shouldn't put our blinders on and not consider these other therapies just because they take away our own personal case volume. I think
Absolutely.
that's the wrong way to look at this.
Of course. What are your thoughts, Dr.
I think
Rodgers?
that's the challenge, exactly right. We have to work to integrate other treatment modalities into our practice, and that's why all of these patients from early stage and particularly the stage 2 and 3 and higher stage patients should be evaluated in a multidisciplinary fashion and cared for in a collaborative way. So I don't view it as a disruptive or threatening new phenomenon. I think it's a challenge for how we'll integrate this into our practice to serve our patients better.
Fantastic.
I think one of the main issues, so at MD Anderson we do have the trial that uses immunotherapy combined with stereotactic radiation treatment. It's called an iSaber trial, and one of the complicating factors of that trial is that nobody really knows at this point, even in metastatic setting, of how long to really treat patients with immunotherapy. Some of the duration of treatment, even for durvalumab, for 1 year afterwards, that was sort of the dose that was selected, but we really don't know whether 6 months, 3 months, or 9 months would be any different. And so one of the issues in very early stage 1 lung cancer, that patients either like to come for an operation and then essentially leave and feel to be cured and go on observation or have SBRT. They don't necessarily want to come back and get an infusion of an immunotherapy drug for even 4 or 5 doses. That's additional 10 weeks of treatment for the patients who come with sort of stage 1 disease, and we cannot at this point tell them, is it going to be beneficial or not? So we still have much to learn about the effectiveness and obviously cost and also side effects of this treatment for very early disease.
I would say that gets to the issue of oncopolitics as well, because name to me a drug company who's going to support a trial that looks at giving 3 months of therapy versus 12 months.
Right.
What's in it for them?
Mm-hmm.
Right.
And so that's going to be difficult to do, and I think it's going to take leaders, physician leaders, to take ownership of this and have either institutional trials or NCI trials that are going to start to look at that question, because I think it's going to be hard to get the drug companies to look at that question.
Yes, but I do think that it's important for us as physicians to also be really cognizant about the cost. Keeping patients for 3 years on immunotherapy at close to $150,000 per year, hopefully we will find some biomarkers or some ways to assess whether this immunotherapy has already created some sort of a long-term T-cell memory or immune memory against the tumors, and that given more does not necessarily mean that it's going to be better in the long run. But I do think that this is again something that needs to be studied, and we need to, for example, look at circulating tumor-free DNA or some other surrogate biomarkers that will tell us that these drugs have already worked and it's safe to stop them.
This has really been a fascinating, enlightening conversation, and clearly there's much still to be learned about immunotherapy and how it impacts our roles as surgeons taking care of patients with lung cancer. Obviously, this conversation is going to continue to change, and if we have this conversation again in 6 months or a year from now, we may have different information to share. But given what we know in the setting of all the information available right now, just wondering if each of you has a brief closing statement that you might want to share with the audience regarding immunotherapy and how it impacts us as lung cancer surgeons.
Sure, I think it's an exciting time to be a lung cancer physician, and I would encourage surgeons when they see patients to engage their medical oncologists if they have patients that they think may qualify for any of the trials that we've discussed and the multitude of other trials that are out there, and work with them in a multidisciplinary fashion to get these trials done and figure out who these drugs are best for and how we can integrate them into multimodality therapy.
Terrific.
So I'd say now 13 or 14 years into my career, the National Lung Screening Trial and now this entrance of checkpoint therapy, it's a very exciting time, and I can honestly talk to my patients and give them a sense of hope about their diagnosis, where that was difficult to do before. And I think that's only going to get better.
I agree with that. I think immunotherapy is here to stay, and I think that it became standard of care very quickly in metastatic setting. I think it's going to make very soon its way into surgical realm, and I think that for us as surgeons, we do need to educate ourselves on these medications and the timing of the operation, and find the best solutions for our patients. But I think that is our future.
And that's why it's critical that we stay engaged in these trials.
Absolutely.
These should not just be run by medical oncologists, but there needs to be a surgeon involved in planning all these studies.
Exactly.
We'd like to thank our panelists for your expertise today, and we'd like to thank you for joining us at this CTSNet Roundtable.